Good afternoon, respected doctors. This is Shivani Sharma Deka on behalf of Spectra, a division of Sun Pharma. I welcome all of you to today, this Saturday afternoon's Indian Society of Fertility's webinar. At the very outset, It's my honor and pleasure to welcome President Dr. Sudha Prasad, General Secretary of IFS, Dr. Neena Malhotra, who has been the person working behind the brainchild behind this webinar. Our chairpersons for today evening, Dr. Manoj Chelani, Dr. Sunita Chandra, Dr. Arunata Khanna, and our esteemed speakers for today afternoon, Dr. Neena Malhotra herself, General Secretary IFS, our most respected Dr. Nagori, and of course, the young dynamic Dr. Aparna Sharma. Hearty welcome to this webinar today on Saturday afternoon. My greetings to all doctors who have connected online for this academic feast today afternoon. Without taking much time, I go ahead to introduce today's Master of Ceremony, Dr. Veronica. Dr. Veronica is an IVF specialist and gynec laparoscopic surgeon. Dr. Veronica is from Raipur at our IVF clinic, and she's the General Secretary of IFS Chhattisgarh chapter. With this, welcoming all doctors connected to this afternoon, Saturday afternoon's webinar, I hand over to Veronica, Dr. Veronica, to take the scientific agenda ahead. Thank you very much. Please enjoy yourself.
Thank you, Shivani. Thank you for that very kind introduction. As an office bearer of the Chhattisgarh chapter of IFS, I feel very proud to be a part of this CME. I take the privilege of honoring our president, Dr. Sudha Prasad Madam, our General Secretary of IFS, Dr. Neena Malhotra Madam, and all the esteemed faculty for this CME. This CME has been planned on progesterone, its various roles right from conception to delivery. With this, I would not waste much time, and I would like to invite and call upon our President of Indian Fertility Society, Dr. Sudha Prasad Madam, for her welcome address. Dr. Sudha Prasad Madam needs no introduction. She is currently she is the President of Indian Fertility Society and bags lot of credits to her, has been a Vice President of FOGSI in the year 2019. And one of the great work that she has done is that she has started the first low-cost IVF at a public sector, which is a remarkable thing. I welcome you, Madam. Dr. Sudha, ma'am?
Ma'am, you are muted.
Okay. Can you hear me now?
Yes, now we can hear you.
Oh, thank you. Thank you so much. And good afternoon to all of you and all listeners. I'm so happy that in this new year, IFS again has become active and giving so much of academic bonanza to our listeners. When we see that this year, Sun Pharma has started the complete, started with the progesterone, which is the essential part, from the implantation, before implantation, and to continue pregnancy. If there is a deficiency, chances are there that either the implantation failure or miscarriages can occur. So I really give credit because I myself, when I started the IVF center at Maulana Azad Medical College in some time in 2007. Since then, Sun Pharma is with me, and always I used to say, okay, write progesterone. But my girls used to say, sustain likho. So this has become in the total, you can see in circulation of the doctors who are just learning the IVF and the ART procedure. So this credit goes to Sun Pharma that he has made this progesterone product absolutely essential to start with this, to start the pregnancy, either by spontaneous pregnancy or the ART pregnancy. And we talk a lot that whether the IUI, if it is done by the letrozole or the chloromethane, we should give progesterone or not. But I know very clearly, because myself also give progesterone support to these unless otherwise we are using any gonadotropin for this, and it gives the very good satisfaction. And at least this pregnancy, which is only through IUI, it is only 12 to 15%, but at least we should achieve this much of pregnancy. So the support is provided to these women also. And I remember at MAMC, we have done the 2 projects. One was the medroxyprogesterone, and other was with the dufaston. That whether the progesterone can replace the antagonist also. And we found that that it is very much important to give to suppress the LS surge. So here, the IFS stalwarts are there to talk about the progesterone, and I hope it will be a very good seminar, and people will be really will be getting the beneficial effect on this and use in the practice. So I wish all the success for this webinar. Thank you so much, and stay blessed. Thank you.
Thank you, ma'am. Thank you for your kind words. With this, I take the privilege of moving on to the scientific program planned out for the day. I invite Dr. Manoj Chinani as the chairperson for this talk, and the first talk by Dr. Neena Malhotra, madam. Dr. Manoj Chinani has been the director of Ayush ICSI Test Tube Baby Center, Raipur, a renowned person, I should say my senior, who has blessed me with a lot of his qualities, has always guided me, has been the founder, chapter secretary of Indian Fertility Society Chhattisgarh chapter. He was very instrumental in bringing this chapter into being, into its existence. Along with this, he has lot of credits to himself for organizing various conferences at various levels and has brought Chhattisgarh to a national fame. Currently, Sir is the president of Raipur Menopause Society and also the chairperson-elect for Chhattisgarh chapter of ISMA 2022 to 24. I welcome you, sir.
Thank you, Dr. Veronica. And it's really a great honor to have stalwarts today, Dr. Sudha Prasad ma'am, Dr. Nagori sir, and Dr. Neena Malhotra, and Dr. Sunita Chandra, and Dr. Aparna Sharma, and Dr. Anuradha Khanna ma'am. And really a pleasure. And I invite you for this CME. And the first talk will be by Dr. Neena Malhotra ma'am, which will be on progesterone prime ovarian stimulation. So I request to kindly share her CV, please. Dr. Neena Malhotra is a very renowned figure nationally, and currently she is the Secretary General of Indian Fertility Society. She is the professor of ART Center, Department of OBGYN, All Indian Institute of Medical Sciences, and she has trained in Scotland and at Yale Fertility Center in Commonwealth Fellow and Boys Cat Fellow, DST, Sir Malcolm Black Fellowship in 2015, and she is Overseas Fund, Imaging Science Award, and CS Dawn Award. And her main interests are reproductive surgery and endometriosis, and her research interests are in endometriosis, genital tuberculosis, and implantation failure. And she is really a good academician, and we are looking forward to her talk, ma'am. So Dr. Neela Malhotra, ma'am, please.
Thank you, Veronica. Thank you, Dr. Chelani and everybody for having me here. So I just not take much time. I would begin my lecture. I hope you can see the slides as I put them on the slideshow. Thank you, Sun Pharma, once again. So as Dr. Sudha really pointed out, progesterone is one of the key players when we look and talk about implantation. right from the nidation, implantation, and moving in pregnancy. And as Aparna will take us through during the second and third trimesters of pregnancy. But I think this talk of mine is a little new, more focused on those who do IVF and ERT, because here we are going prior to implantation and we're looking at newer, options that way we can exploit their potential even in ovarian stimulation. Now, having said that, I think as IVF specialists, we are looking forward to a good number of follicles, a cohort which gives us competent, mature M2 sites, which we have in the last sort of, 4 decades learned. Ever since Louis Brown, though she was born from a natural cycle, I think we have really toiled hard to understand that we do gonadotropin stimulation, we do suppression of LH, which is very, very paramount when we stimulate to get a cohort of 12 to 15 eggs in a cycle and triggering ovulation. And this we really tailor make when we are depending on whether our patient is a normal responder, she's a poor responder, or hyper responder. I think we really, really tweak our, sort of cycles to our understanding. And this is how we go about. But then we have to realize that whatever said and done, there are multiple challenges because we still face asynchronized cohort, maybe the biggest challenge being premature LH surges, which may give us poor response, even in normal responders, getting us too many immature oocytes, fewer euploid embryos, and of course, an asynchrony when we push too much of gonadotrophins, resulting in not the way we want, lower pregnancy and lower live birth rates. But then I think a challenge which we have been struggling with agonist or antagonist cycle, I think still, despite the use of good antagonist available, we have the premature LH surge always lurking in most cycles. So to combat that, I think we have tried to understand, can we take care of stimulating the patients a little different, i.e. go from a follicular to maybe different starts, and again, on looking at novel methods of LH suppression other than the agonist and the antagonist. So then I think we have to look, are we having options other than the analogs? And of course, the options are progesterones. Really, have they found a place, or are we still understanding what are the protocols? And if we have the protocols, what is the efficacy and safety? Of course, the success and the downsides, and what is the future that we look in progesterone primed ovarian stimulation? So I think if we look at the conventional start where we give a flare up, there is a LH surge, and then we try to downregulate it with whatever analogs. I think there are newer methods which can be sort of used to tackle this LH surge. Some endogenous, that means we sort of exploit or harp on the endogenous methods, i.e. we begin in a luteal phase instead of the follicular phase, maybe do random start or dual stimulation. I think this endogenous progesterone suppression comes mainly in poor responders or the cancer survivors in whom we do a start of ovarian stimulation. But something which we can do other than our poor responders and cancer survivors is use of exogenous progesterones, which we call as progesterone primed ovarian stimulation. Now, why have we thought of really only progesterone? I think the simple reason is that with conventional, and this is the way they will find a place in the future, is on the cost factor, because when you use progesterones, they turn definitely friendly on the pocket of the patient. Again, we know conventional analogs, agonist or antagonist, are injectable. We also fear the risk of OHSS, cycle cancellation, less number of oocytes, and needless to say, when we are using progesterones for ovarian stimulation, we have to depend on cryopreservation. So I think the very big reason for us to really think on progesterone is that in the present day, in the present decade, we have learned cryopreservation methods really well. We have really mastered vitrification with good success, and therefore we have trying to venture with this newer method of ovarian stimulation. Now, this is a beautiful article which is there in Human Reproduction Update recently, or not so recent, but in 2017, where Natalie Masson has talked about how LH is bothering during an ovarian stimulation, and I think there are a lot of methods, including progesterone primed ovarian stimulation. But remember, whenever we do this, we would have to freeze all. That means we cannot do a fresh embryo transfer, be it progesterone primed ovarian stimulation or a dual stimulation or random start. And therefore, units who plan to do all these newer methods should really fall back on a good embryology team where they have a robust vitrification program. So just to understand how do progesterones work, I think this is something which we've learned right from the first year in physiology, that prior to ovulation, there is, the LH, there's a mild increase in the progesterone. And also there's a slight increase in the estrogen levels. And post LH, or the post-LH surge, when there is ovulation, there is a definite rise in progesterone, the progesterone rise being more significant than the transient rise that happens. And then subsequently, there is the luteal implantation window, which opens up to allow the fertilized egg or the embryo to implant in a natural or a fertilized cycle. Now, we know that this is how it works, and this is how this LH surge works to bring about ovulation, followed by a significant rise in progesterone. Now, the endogenous induced LH surge is actually working from the pituitary and the hypothalamic axis, whereas the progesterone-induced LH suppression, which acts to induce or which induces the LH suppression, is basically a hypothalamic action. So we must realize that this progesterone is working on the hypothalamic pathways to suppress LH suppression. So how does it work really? You know, at one side, we are worried that this LH will be sufficient enough, but we have to realize that the actions of progesterone really depend on the timing in which we are giving them, and also on the duration or the doses that they work in the cycle. So, you know, if we look at it, it may be synergistic as well as antagonistic. So if you give it in the luteal phase, it works synergistic to estrogens. However, if you give it a little early in the follicular phase, it becomes antagonistic. Again, if it's given early in the estrogen, in the early part of the cycle, it is independent of the estrogen phase, and therefore that's the way it works to prevent an LH surge. Whereas if you give them in moderately high doses, it even goes about to inhibit ovulation, and that's the reason why we use progesterones in combination with estrogens in combined estrogen progesterone pills. But mind you, when we're giving it as early in the follicular phase, there is a potential harmful effect. It just knocks out the endometrial receptivity, and for this reason, it's an absolute no-no to consider that you will put back these embryos in the fresh cycle, and therefore you have to think only of nothing but a frozen embryo cycle in which you will have to put in the embryos in a few cycles later. So which are the patients where we could use this newer method of ovarian stimulation using progesterones? Particularly in those women who've got high LH, as in PCOS, those who have poor reserves, and also in normal responders like donor oocyte cycles, where we are thinking of cost as a factor. So let's look at how they work. I think this article by Antonio Lamarca is again a must read for people who really want to learn this technique or master it. So like in the conventional, when we're beginning to give antagonists, beginning with our cycles that we've understood in embryo transfer, here we begin giving with gonadotrophins from the second or third day instead of simultaneous with the gonadotrophins. We start giving them oral tablets of progesterones, and then go likewise monitoring our patients and give a trigger, preferably by agonist, or for that matter, a dual trigger, and then do the pickup and embryo freezing. Now, there are a lot of these products that are available, right from micronized progesterone to dihydrogesterone, medroxyprogesterone acetate, and medroxyprogesterone, which have been used. And the three commoner ones that I will be talking in the review of literature that I have reviewed is medroxyprogesterone, micronized progesterone, and lately dihydrogesterone, which has also been used for stimulation. Now, how do these agents being given? Medroxyprogesterone is given as 10 milligram once daily. It's a good, strong pituitary suppression. The good bit is it doesn't interfere with the endogenous progesterone levels. So when you're monitoring your patients during stimulation, the progesterone levels would not vary. But the only thing that has come from a lot of studies is that when they're given, they tend to cause a larger doses and a longer duration of gonadotrophins being used as compared to the conventional agonist or antagonist protocol. In contrast to the micronized progesterones, which are given in dose of 100 milligram twice a day, the possible downside is that they interfere with measurements of the progesterone, which some clinicians would do during monitoring of the cycle. And of course, dihydrogesterone is again, which is as good as effective as medroxyprogesterone and has got equal advantages. So how do we give the protocols? You start them on day 2 or day 3, the same day as you start the gonadotrophin. This is a standard start that has come in most of literature. However, there is also a flexible start, which has got just 1 or 2 articles where say that you can start progesterone like you start an antagonist. That means the day you get a lead follicle of 12 to 14 millimeters, you could do a progesterone suppression on the same day. I think it looks a little more adventurous as there's very little data on this. Well, this is a standard way to stay. What about the monitoring? Is the monitoring going to vary? Well, the ultrasound monitoring will be as you do for a conventional start. However, in terms of hormone assays, I think when I was reviewing the literature, most papers have come from China, and just 1 or 2 units who have published maximally believe in doing a serum FSH, LH, and E2 as we all do with progesterone on cycle day 2 or 3, that is on the day start. However, initially they did repeat their patients on day 9 and day 11 with the LH and E2, LH and P4. But I think as time went back and with the experience in the newer articles, they're just believing in monitoring them with only ultrasounds. Now, looking at the first, paper which came from Kuang, and I think Kuang is the one who gave the Shanghai protocol in poor responders, well presented in 2009 and 11. I think they have used this same ideology of progesterone suppression in Clomid gonadotrophin cycle, which is called the mild stimulation protocol. This was their first paper, which came after the Shanghai protocol. And clearly they used 300 patients who were undergoing a retrospective paper, a prospective control trial in which they did close to 300 patients who were undergoing IV ICSI, and they combined HMG, which is human menopausal gonadotrophin, with medroxyprogesterone co-administered beginning from cycle day 3, triggering them with an agonist. And then the cycle which had HMG MPA were co-triggered with both agonist and an HCG when the follicles reached a maturity of 18 millimeters. The primary outcome that they saw was a number of oocytes retrieved, and the secondary included the number of mature M2s and what was the incidence of premature LH surges. Now, when they found the results, they found that the medroxyprogesterone was as effective even in preventing not only the premature LH surges, but also in the amount or the number of M2 oocytes that they got, and finally, the number of embryos, good quality embryos available for cryopreservation. So they went on to say that this is an equally effective method of LH suppression, and being oral would be accepted. Now, the same group went on to use a combination, and they wanted to check in whether they can use other than medroxyprogesterone, and they went ahead and used dydrogesterone. And this was a cohort of a little over 400 patients. Particularly, this study was from PCOS patients where we fear premature LH surges. They used one arm in this. They found one arm of the study was given HMG MPA, and in this cohort, the other half got HMG and dydrogesterone, beginning likewise on day 2 or day 3. And of course, when they looked at the result, there was no difference in terms of the oocytes, the quality of embryos, and even live birth. So they felt that even dydrogesterone was equally effective as medroxyprogesterone when it comes to stimulation or priming the cycle with progesterone to prevent LH surge. Now, having understood the bit, I think this is another paper which comes again from not the same group, but from the same hospital. It's a different group, which are co-triggering the patients on HMG or HMG gonadotrophin used with medroxyprogesterone versus dydrogesterone. And again, there was no difference in the outcomes. But mind you, this is all the cycles where they are freezing the patient. So the very important thing here is that if you embark on this kind of a stimulation protocol, you have to freeze on. Now, they've moved from PCOS patients to other groups as well, which included tubal factor infertility. That means they use it in even in normal responders besides the hyper responders. So this is all the kind of studies that have come out from Kuang and even from Zhu, both Chinese papers, which have looked at progesterone priming vis-a-vis compared against a short agonist. In fact, the thing is that I could realize that in the Shanghai hospital, they are using a short agonist protocol, which I think we all are not using much, or we rather use very little in our part of the world. Now, again, there was another paper which comes again from Zhu's center, which is again in China. And therefore, this has gone further to look at micronized progesterone, eutrogeston, and they gave doses of 200 milligram, that means 100 milligram twice daily, where the primary outcome measure was prevention of premature LH surges and also the use of embryo quality and pregnancy outcome. So again, this study said that eutrogeston was compared. In fact, in this study, they used 100 milligram versus 2 doses. That means 1 dose of 100 milligram versus 100 milligram twice daily. And they found that even 100 milligram is a sufficient dose sufficient enough to prevent an LH surge. So having this, I think the big problem that we can sort of understand is it is really all wonderful. Well, really, yes, in terms of advantages, but not really absolutely the one which we would take on. Because though it's orally administered, we know that there is a reduced consumption of gonadotrophins, particularly in women who have PCOS. Also, the incidence of OHSS reduces. I think there is a downside, and the biggest downside is that you need to have only frozen embryo transfer. Again, what you'd require is a dual trigger. So on the terms of cost, if you're thinking you're reducing the cost using an oral product, you have to say that you are countering it with also an increased requirement on the lab where you're needing to freeze all embryos, which may be an added cost. And more so, you need a dual trigger because you're wanting to get more mature M2 oocytes. When you're looking in terms of outcomes, I think they're both comparable, but then most data here has been compared to short agonist trials. So we really don't have, outcome which is compared to cycles which are antagonist till the few papers as I take you through have come, and also even with the agonist, what some of the centers in Europe would use. Now, further, we really do not know what is the long-term outcomes in terms of aneuploidy risk that happens to the embryos that are potentially coming from such stimulation protocols. Now, this is again a paper which was looking at comparison of the flexible progesterone prime ovarian stimulation with the flexible antagonist protocol. So this is a paper which comes from Turkey, Baris Ata's group. And I think this was something which got inspired by the works and publications of the Chinese paper. And then they looked at their retrospective cohort where they had 87 egg donors. So, this is one place where we really want to save costs because egg donors are ones who are younger, they are normal responders, and that's what we really want. And so in this group of patients, they tried to compare the standard antagonist, where they're giving an antagonist starting in a flexible mode when the dominant follicle reaches 12 to 14 millimeters, vis-a-vis starting on the same size, we're giving medroxyprogesterone acetate. And what they concluded that they found that medroxyprogesterone acetate primed ovarian stimulation was as good and as effective, not only in terms of the LH surges, but also in terms of the blastulation rate, the cleavage rate and implantation rate and live birth rates in those with ongoing pregnancy. Definitely, here the issue of freezing does not arise because you are implanting or you're putting back the embryos created from such a stimulation cycle into the recipient who is not getting disturbed by or who's not affected by these disturbances of progesterone on the endometrial receptivity. So this was one potential use which was really coming up, and I think this is the way where I think progesterone will really, really have a strong hold. So looking to some newer papers, again, this is one of the papers where they looked at switching again in women who are at risk of OHSS, i.e. group of patients who were, a PCOS, where they thought that women, and I think this is a very small study, I would say a retrospective cohort, which is looked at giving patients antagonist in the standard way as they give in any patients of PCOS, triggering standard triggering with the use of, at maturation with an agonist or HCG. But then in a woman where we are fearing that she will develop OHSS, you can switch over from using antagonist to medroxyprogesterone because they believe that you're saving the patient's, cost, but also you get a stronger or a far superior LH suppression because that is the culprit in causing OHSS. But then I really cannot say this is just one paper, whether really the OHSS rates were lowered per se because of the freeze-all or medroxyprogesterone. I think it'll be very difficult because we need more data from papers or thoughts like this. Now, there is, again, some work where they have looked at does the, outcome of mature oocyte retrieves and blastocysts, does it look, how does it behave in terms of the match controls? And I think they looked at the duration of ovarian stimulation was longer. This paper said that when they used medroxyprogesterone, they found that the ovarian stimulation went longer, not only in days, but also doses in the group which got medroxyprogesterone acetate as compared to the antagonist. But what was important is they found that even though there was a lower risk rate of blastulation and the blastocyst number was low, but what they found at the outcome end was that there was a similar live births. So I think this is again a paper which comes from Turkey. So we're beginning to realize in 2020, JARG, this paper says that even though there is a longer duration and dose of the stimulation with gonadotrophins, the outcomes in terms of live birth stands similar. So then with the freeze-all protocol, I think it becomes important for us to understand that this may be a way to reduce, even though reduced blastocyst numbers, the live birth rate is similar in both the protocols. Now, some work, I think, where we really, some group of women where we really worry about premature LHs are poor responders. And I think this is again a paper which again comes from Chinese side of the Chinese hospital. And this is again saying that when they primed the women with progesterone and minimal stimulation protocols, they got almost a better outcome as compared to the antagonist protocol. Sorry, this was not antagonist, they were comparing with natural cycle. So I don't think we really would stress a lot because I think in India, we really don't work on the natural cycle way of stimulating poor responders. Now, again, some work which comes from Europe, and this is from Spain, which compared medroxyprogesterone from granules, because, till 2017-18, most of the paper was coming from China. I think what inspired from the inspiration, what researchers got, I think it's moving from east to west, the concept moving from China to Turkey to Spain. And I think this paper again looks at medroxyprogesterone. What they found in the donors, they had significantly lower number of not only oocytes, also good quality embryos. So this was one paper, the first of its kind, which gives us, well, it is a little early, and a bit of caution which comes from this paper. Now, a place where I think this would really find place in terms of saving costs would be dual stimulation. I know that some of us have begun, and I think we at AIMS have started doing dual stimulation for some of our poor responders, where we know that we're giving the standard antagonist with the agonist trigger at the ovum pickup. We give a gap of at least 2 to 4 days. And then in cashing on that, the theory or the ideology that in one cycle, a woman undergoes multifollicular waves of, ovarian recruitment. And I think you can go ahead and start a second stimulation in one cycle. That is the ideology of dual stimulation, or two stimulations in one cycle. And that's where we start adding antagonist in the second phase of the stimulation. It is here that we could replace the antagonist and replace them with medroxyprogesterone or oral progesterones. And that's where I think costs would certainly come down. In fact, when I was sharing this experience with some of my colleagues in the private, they said that they are rather relying in these poor responders of using both the LH suppressions, using even the first phase as well as the second phase with medroxyprogesterone, and they're getting good results, particularly in terms of cost cutting, because at the end of this kind of stimulation, we will have to be freezing also. It becomes more reasonable to use medroxy in both the first and the second half of LH suppression for LH suppression. Now, this is one paper. The next question really asks, is there anything in which we have used progesterone prime double stimulation versus flexible? In fact, this is one clinical trial which has been registered in the trial registry, where they're going to compare a progesterone prime double stimulation. As I said, both the first and the second stimulation being covered by medroxyprogesterone, and then they're comparing it with the flexible antagonist protocol in poor responders. So let's see what the results of this study come. This has been coming from Egypt. Now, really, the big concern which comes is if we are looking at some studies saying, yes, it gives us a fair number of embryos, the blastulation rates are good. What about diploidy? I think that's what we are worried about. Do we get the same quantity or quality? I think quality morphologically or quality on terms of their ploidy. And I think this paper says, yes, they have been similar in even terms of their, euploidy. So the euploidy rates are almost similar in terms of the blastocysts. Now, what about the newborn? I think that's the next concern. Again, work shows that this meta-analysis clearly shows that the outcome of these children is no different from the ones, but it's a little early because it's just the newborns. Again, I think as I'm going past time, I'd say this is a meta-analysis by the Turkish groups, which clearly say that this will have a wider implication, an option for women who are not going for a fresh transfer, i.e. women who have fertility preservation, who are hyper-responders, where we know we'll have to go in for a PGT and also for the dual stimulation besides the oocyte donor. Again, on the neonatal outcome, I think there is data which says that the neonates from this retrospective cohort from China, over 3,500 newborns, have been no different in terms of congenital malformations, even with the dydrogesterone. So it is like kind of, but then let's look at the SWOT analysis. Well, definitely strengths are for their cost, they're well tolerated. But as I said, weakness is definitely that we don't have still randomized trials. We have to freeze. But then there are far too many opportunities that we can look at. And I think that is what are the opportunities, looking at them in donor cycles, fertility preservations, those with PGTA, PGTM, and of course, women who will be going in for a non-conventional IVF protocols. So I think I will just end here that though it's the beginning of a newer stimulation protocols, we have to realize that we have to fall back on more randomized trials, more data, and we would also have to look in terms of the long-term outcomes of the babies, because we are still beginning to learn this newer protocol. So I will just end here, and thank you very much for your patience.
Thank you so much, Neena ma'am. It was really a wonderful talk and not very so common. And it was really a learning experience for all of us. And we'll definitely try it. Thank you so much. We'll take questions at the end of the session, or madam has to go. There are no questions yet. Thank you. Thank you so much, Neena ma'am. Thank you.
I think we'll move on to the next talk. With this, I take the pleasure of inviting Dr. C.B. Nagori as our next speaker, sir, and Dr. Sunita Chandra as the chairperson for this session. The ma'am is the Hospital and IVF Center Director, Morpheus Lucknow Fertility Center. She is currently the chapter secretary of IFS Lucknow chapter, is a national faculty and has presented various papers, published various papers, and has many awards to her credit. I welcome you, ma'am. Hand over this session to you.
Yeah. Thank you. Good afternoon, everyone. Thank you, Dr. Veronica. Thank you, IFS, for giving me this opportunity to introduce none other than Dr. C.B. Nagori. I mean, he is the pioneer in explaining role of ultrasound in infertility. I'm hearing him for many years, and I'm really fond of him. He's a director of Nagori Fertility and IVF, and he has the credit of first stem cell pregnancy in India. He has published several papers in index journals. He is holding continuous trainings for infertility, IVF, and ultrasound, and authored a very popular book, Handbook of Infertility and Ultrasound, for practicing gynecologists. We are going to hear him regarding role of progesterone in luteal phase. And I think by end of his talk, we will be taking the message that whether we should use one progesterone for luteal phase support or mixed progesterone. So, dais is yours. Sir, please go ahead with your talk.
Thank you very much, Sunita, for the kind words at the outset. I'm thankful to IFS office bearers, to all, as well as thankful to Manoj also. At the outset, I'm thankful to Sun Pharma also for sponsoring this program. I'll be talking on progesterone in the luteal phase support in ART. Okay. So I'll be discussing the luteal phase support in ART. Why do we need the luteal phase support in an ART? We are using gonadotropin cycle, we are using HCG trigger, we are using GnRH agonist for down regulation, using antagonist for prevention of an LH surge, agonist trigger and FET cycle. Now in these various conditions, how do we plan for the luteal support? Now whenever we use a luteal support in a gonadotropin cycle, what happens? There are supraphysiological levels of E2 with hypothalamo-pituitary complex for decreased LH secretion because of the negative feedback mechanism. So in all the gonadotropin cycle for ART, we are using gonadotropin, and that is why the exogenous gonadotropin will definitely decrease the endogenous LH level. And whenever the endogenous LH level decreases, we do require a luteal support for this condition. Second thing is, this low LH is due to the high E2 and progesterone that indicates the need for the luteal support. We may be using along with the gonadotropin, agonist, antagonist, and exogenous HCG. All these require a luteal support. And that is why in all ART cycles, that is in all stimulated cycle, we require a luteal phase support. Now, in a luteal phase, in HCG trigger, what happens when we give an HCG trigger for the fresh transfer? Whenever we use an HCG trigger, this is an exogenous LH. And whenever we use this exogenous LH, it decreases an endogenous LH. And that is why there is always a luteal phase defect because of this exogenous LH. Now, in an earlier part, because we are giving either 5,000 or 10,000 units as an LH surge, exogenous LH surge, so it will take care for the first 5 days of the luteal phase. So that is why the luteal phase defect occurs after the 5 days. It does not occur for the first 5 days. And that is because of your 10,000 HCG. But the luteal phase defect definitely occurs because the endogenous LH decreases because of this HCG which is given. So that is why the luteal phase defect occurs from day 5 onwards. Now, when the pregnancy occurs, the implanting embryo will start secreting beta HCG from 8th day onwards. That will rescue the corpus luteum. So the HCG which is you have given exogenous will work for 5 days, and from day 8 onwards the pregnancy will take care of the corpus luteum. So this is the luteal gap between day 5 and day 8. There is always a luteal phase defect. And if the progesterone is not supplied during this phase in an ART cycle, lot of chemical pregnancies, lot of abortions or the implantation failure occur only for this reason. So that's why those who are giving HCG for the ovulation trigger, the luteal support must be started from at least day 1 or day 2 onwards and should cover the day 5 to day 8. Otherwise, the chemical pregnancy or the implantation failure will occur. So this luteal gap is always to be covered. Second thing is when you give HCG trigger, it impairs the corpus luteal function by disturbing the anterior pituitary function in spite of the high E2, and that impairs the LH surge. This effect is ignored, I told you, because of the HCG that you have given. But after 5 days, the luteal phase defect occurs. Now, GnRH agonist and the luteal phase support. Whenever you are using GnRH agonist for the down regulation, this is particularly common who are dealing with the batch IVF. So those who are dealing with a batch IVF, they would like to use the agonist as a down regulation. Otherwise, majority cycles at present in the world are with an antagonist. But suppose you have used agonist, this agonist will suppress the FSH and LH, and that is why there is always a luteal phase defect whenever you are using agonist as a down regulation. So judicious luteal support is required, particularly when GnRH agonists are used for down regulation. Now, antagonist and luteal phase support. When we use antagonists, there was a former belief when antagonists came in the market after 2003 or 4 onwards, people were not giving the luteal phase support because people used to believe that antagonist does not cause a luteal phase defect. And lots of pregnancies were wasted at that time because the luteal support was not given in the initial papers. But then it was realized that antagonist suppresses an LH level, and at least it is given for at least about 4 to 5 days. And this suppression of LH is going to hamper the luteal phase. And that's why the luteal phase defect occurs because of the decrease in LH in the follicular phase. So the luteal phase support is always required, particularly whenever you are going for antagonist cycle. Antagonist down regulation decreases the risk of OHSS also. And second, the main advantage of using an antagonist is that you can use an agonist as a trigger for the prevention of an OHSS. So in all the antagonist cycle, if you are going to transfer a fresh transfer, then the luteal support has to be given to all the patients. GnRH agonist trigger and the luteal phase support. Nowadays, almost majority of the centers are going for antagonist cycle, and when you go for an antagonist cycle, the GnRH agonist is used as a trigger. As a GnRH agonist, you can use leuprolide acetate 2 cc can be given to the patient, or decapeptyl 2 ampoules can be given straight to the patient, and after 35 hours, you can do an ovum pickup. Now, this agonist trigger does not cause the OHSS. The reason is that it gives a very short duration of an LH surge. Now, when the duration of a LH surge is short, this can complete the meiosis, but it is inadequate for the luteal support. If you consider the total duration of an LH surge because of the GnRH agonist, is 4 hours is an ascending curve and 20 hours is a descending curve. So it is almost about 24 hours. But if you consider a natural curve, natural LH surge, then it is 14 hours ascending curve, horizontal curve will be 14 hours and descending curve will be 20 hours. So it will be almost about 44 hours will be there. So that is why the duration is short in a GnRH agonist trigger that will complete the meiosis, but it is inadequate for the luteal support. So whenever you use GnRH agonist trigger for judicious luteal support is always required for all these patients. Nowadays, we are using GnRH agonist trigger, particularly when you want to avoid the OHSS, you want to freeze all the embryos, or you want to do PGS or PGD for the aneuploidy screening or for genetic screening, then you would like to freeze the embryos and transfer in the next cycle. In this cases, you can use GnRH agonist trigger. This is the most common trigger that we are using nowadays is for the donor cycles. Now, suppose you have given a GnRH agonist trigger and you want to do a fresh transfer. Now, when you want to do a fresh transfer, how would you like to give a luteal support? The luteal support can be given in intensive exogenous E2 and progesterone. You can go for dual trigger. You can give HCG at the time of retrieval. You can give low dose HCG in the luteal phase, or you can give a recombinant LH. Let us consider one by one. Intensive exogenous E2 and progesterone support in a fresh transfer. It is particularly given whenever you have given agonist trigger in the high risk of OHSS patients. Here you give intramuscular 25 to 50 milligram, or at present the subcutaneous injections are available and you can give 50 milligram, 25 to 50 milligram of subcutaneous aqueous injections, and you can give 800 milligram of the vaginal progesterone can be given to this patient along with 2 to 8 milligram of the estradiol valeric tablets. Now you have to adjust E2 at 200 picogram per ml and progesterone 20 nanogram per ml. That will give the same results as that with an HCG. So rather than giving HCG and the patient may end up in an OHSS, it is better to give the agonist trigger and then you can use the judicious E2 and progesterone and you can definitely prevent the OHSS to the patient with an equal pregnancy rate. Now the second thing is the dual trigger. I told you that this can the GnRH agonist trigger can complete the meiosis, but it cannot fulfill the criteria for the luteal support. In sum of why it completes the meiosis, because the LH surge occurs at that time. But if the LH surge does not occur in spite of her GnRH agonist trigger, that is common particularly in those patients who have taken OC pills for a very long time, or there is an hypothalamic suppression for a very long time. So in spite of giving GnRH agonist trigger, this patients will not get a sufficient LH surge. And when there is no sufficient LH surge, when you do a pickup from the first ovary, you won't get a single follicle. So it is not an empty follicle syndrome. This is because of the decreased LH surge that has caused that not a single eggs you have found out. So you stop the procedure, you give HCG to this patient once again and do a pickup after 34 to 35 hours, then you will receive the OA. But instead of that, what you can do, that you can give a dual trigger to all these patients. That dual trigger means you give 1000 units to 2500 units of HCG is given. I tell you that in an IUI cycle or when you want to do a pickup, we are giving 10,000 HCG to a patient in a fresh transfer. Now out of this 10,000 units of HCG, 500 units are required for completion of meiosis and 9500 units are required for the rupture of the follicle. And that is why there is no point in giving 10,000 units to any patient for the transfer, or rather for the ovulation trigger when you are going to do an IVF, because you are doing a pickup. And that is why there is no need of rupture of the follicle. And that is why what you require only 500 to 1000 units of HCG, which will be enough for the completion of the meiosis. So to take an advantage that in some of the patients, the LH surge may not occur. So instead of that, you combine 1000 units of HCG along with the GnRH agonist trigger, then you won't come across any patient of empty follicle syndrome because of the decreased LH. And this is our routine that we, in all the patients, we always give in a fresh transfer, particularly when we have given GnRH agonist as a trigger, we always give 1000 units of HCG to all the patients. So it works as a backup in a GnRH agonist failure and additional signal for luteinization. It is preferred over HCG at the pickup due to the low OHSS rate in the high risk group. So that is why the dual trigger has become very popular nowadays, that you never come across the decreased in the LH level and you get the sufficient number of eggs with the good maturity. Now HCG at the time of the oocyte retrieval, this is typical Professor Humidian paper, that when you get less number, that is less than 25 follicles of between 11 to 14 millimeter size, then at that time you should give 1500 units of HCG at the time of an ovum pickup. Now remember here, two things are to be remembered. If you do serum estradiol, that is fine. If it is more than 4000 units, or if it is more than 25 follicles of more than 11 millimeter, then you have to freeze all. There is no point in giving HCG 1500 units. But if the number of follicles are less than 25, then you can give 1500 units and you can do the same the transfer in the same cycle. And that gives an excellent pregnancy rate. But remember that the second dose of 1500 international units should never be given to any patient. Otherwise, the incidence of OHSS is very high. So less than 25 number of the follicles, give 1500 units of HCG at the time of an ovum pickup. That will rescue the corpus luteum, and the pregnancy rates are very good, and it will take care of the luteal phase. Recombinant LH is very expensive, even though it has got low incidence of OHSS. In future, some analog of LH would come, and then the cost will come down. But at present, it is not commercially possible to use the recombinant LH. Now, in FET cycle, we give a luteal phase support. In FET cycle, we normally use FET cycle for prevention of an OHSS, PGS, PGD is required. Progesterone more than 1.5 nanogram pre-ovulatory, fluid in the cavity or single embryo transfer, or the patient or the clinician choice, we go for FET cycle. And in an FET cycle, we have a natural cycle, modified natural cycle, artificial cycle, and agonist cycle. Now, natural cycle, estrogen and progesterone are delivered from the spontaneous follicular development. And here we normally use an LH urinary kits or the blood test help in detection of the ovulation one with the embryo transfer is decided. Embryo transfer is done on day LH plus 6th day. Now here, in several cases, the endometrium is out of phase because of an inaccurate ovulation. So formerly it was believed that the luteal phase support is not required and does not improve the results. But now so many papers have come up that even in a natural cycle, you have to give the progesterone support to all these patients. And a modified natural cycle, when you give an HCG, that will rescue the corpus luteum, and perhaps the luteal phase support is not required. But the natural cycle and modified natural cycle, the results are the same. Almost all the centers are going for an artificial cycle where you give estradiol valerate 4 to 12 milligram for 2 to 3 weeks. Now, it is very important that whenever you are going to do a freezing transfer, the estrogen should be given in a dose of 4 to 12 milligram. Preferably, we give one tablet, that is 2 milligram 3 times a day. And that should be given from day 2 onwards. There is no point in increasing doses like 1 tablet for 3 days, 2 tablets for 3 days, and then 3 tablets. It has got no place. You can start minimum 4 milligram, and ideally 6 milligram should be given, 1 tablet 3 times a day. And that should be given minimum for 12 days. Now, this is very important that if you give E2 in a freezing cycle, then it should be minimum 12 days and it should not be more than 28 days. So many a times it happens that because of the estrogen on 7th or 8th day, you may get a good endometrium and you are tempted to do a transfer after starting the progesterone. But please don't do it. For development of the progesterone receptors, minimum 12 days are required. And after 28 days, it has been found that the results are not good. And that's why I try to do the transfer before after starting the progesterone. That should be started before 28th day. Transdermal or the oral drugs have got the same results. And when you are starting 4 to 6 milligram of the estradiol valerate, from day 2, it will not allow the endogenous follicle to develop. And that is why your control is from outside. And that is why you can start the progesterone according to your desire. Now, one thing I forgot to tell you, that when you get a good endometrium, don't be tempted to start the progesterone to these patients. You should get the vascularity in zone 3 and zone 4. Unless you get a vascularity in zone 3 and if you start the progesterone, do a transfer, the pregnancy rates are very poor. But if you get the vascularity in zone 3 and then if you start the progesterone, the pregnancy rates are very good. We are coming out with one very good paper in future that if the vascularity in zone 3, the pregnancy rates are excellent. So you may have to wait for a day, 2, 3, 4, 5 also. But unless you get a vascularity, please don't start the progesterone if you want to get an excellent result. Now, before the vascularity has developed, you start a progesterone, if you don't get a pregnancy, and after 1 or 2 failures, you will consider that this is a recurrent implantation failure. It is not a recurrent implantation failure. I will consider it as a personal failure because you started progesterone too early before the vascularity developed in zone 3 and 4. So that is why once you get it in zone 3 and 4, then and then the progesterone should be started. The pregnancy rate will be excellent with these patients. So when you start a progesterone, suppose I give you an example that you have given it for 14 days. Now the day 0 will be on which you will start the progesterone. So day 0 evening, you will be starting the progesterone. And the next day onwards, you will starting the progesterone if you are using vaginal tablet 400 3 times a day. And second is the cream that you have to, or you can start the cream also, one in the morning, one in the evening. But I would like to tell you that there is one paper, I think I'll be touching afterwards, that you have to start subcutaneous injection to all these patients. So day 0 means you start the progesterone, day 1, 2, 3, 4, and day 5 the transfer is to be done. So day 0 you start the progesterone, day 1, 2, 3, 4 you have to give subcutaneous injections, aqueous injections to be given, either 25, if the patient is obese then you have to give 50 milligram to these patients, and the results will be excellent. I think Sunita asked me a question that we should use how many progesterones, and the combo preparations or the so many progesterones are used by majority of the people. I remember only one thing, that either you give a vaginal tablet 400 milligram 3 times a day, and along with it you should give and subcutaneous injection, aqueous injection 25 milligrams should be given. No other oral drugs are required for the patient. No other injectables like intramuscular oily injections are not required for the patient. So either you can give vaginal tablet to the patient, or you may use the cream for the patient, but along with it you must start the subcutaneous. This is a very good paper that when the progesterone 800 milligram per day was given in an FET cycle, the progesterone level was less than 9.2 on day 7 in 25% of cases. And that is why you should give subcutaneous aqueous injection to all the patients, and that has improved the pregnancy rate excellently. So intramuscular or subcutaneous 25 milligram of aqueous injection should be given to this patient daily. If you are using intramuscular, then every third day it should be given. But nowadays we have switched over to subcutaneous injections only. So what is to be understood from this? This explains that except E2 and progesterone, all the substances like androgen or peptides secreted from the ovary are harmful and not good for uterine receptivity. That is why forget about all cytokines, forget about everything. You should know how to manage estrogen and progesterone, then your pregnancy rates are very good. Except estrogen and progesterone, the endometrium does not require anything. Endometrium does not require anything. And that is why please don't add any other thing except estrogen and progesterone. The pregnancy rates will be very good. See, this is a paper that when 800 milligram was given, an addition of the progesterone has given the higher pregnancy rate. Now here I would like to tell you one thing, that there is one recent paper, that is a Japanese paper, that instead of 800 milligram, if you give 1200 milligram of progesterone, 400 milligram 3 times a day vaginal tablet is given, then it gives an excellent results. So we have switched over to 1200 milligram nowadays instead of 800 milligram per day. Agonists are routinely not used. Now, we have discussed that in which conditions the luteal support is required. Now, what to use for the luteal support? You've got progesterone, you've got HCG, you've got GnRH agonist, and you've got an additional E2 is required. I already discussed that the luteal gap requires a progesterone. Norethistron acetate, MPA, that should be avoided because their effect on the androgen and corticosteroid receptor. That is why I think Neena Malhotra has already discussed that if you are using a progesterone, it has a bad effect on an endometrium. That is why all the freeze cycles are there. You cannot transfer in the same cycle. And that is why all these oral progesterones have got no role. Micronized progesterone is always the best. Now, the progesterone that is available is intramuscular, subcutaneous, transdermal, oral, and vaginal progesterone. Intramuscular progesterone has almost gone out from the picture because it is severely painful, and most of the cycle are cancelled by the patients, or what after the failure, patient does not want to go for the second cycle because of the pain of the injections rather than the failure. That is why don't go for these intramuscular injections. These are very painful. Instead of that, subcutaneous injections are available to you, and that is 25 milligrams subcutaneously can be given. The results of 25 milligram and 50 milligram, they are the same. There is no difference. And that is why subcutaneous injections can be given to all the patients. And the safety is also very good, and it is as good as the vaginal tablet. Transdermal progesterone is never popular because the amount of progesterone is 25 milligram per 24 hours, while that of the E2 is only 0.5 milligrams. So such a large dose cannot be given by transdermal progesterone. And second is 5-alpha reductase that deactivates the progesterone, and that is why this route is not preferred. Vaginal progesterone is always the preferred route for all the progesterone preparations. Now the advantage of vaginal progesterone, first uterine pass effect. So from the vagina it goes to the cervix and then it goes to the uterus. So it goes straightway to the uterine effect, and this is the reason why the serum levels are always low, but the concentration in the uterus is always very high, and that is why vaginal progesterone is preferred. Second very important mechanism is a counter current exchange mechanism. Now, what is a counter current exchange mechanism? There is a special arrangement of the vaginal and the uterine vessels in the upper third of the vagina that when the drug is absorbed from a vein, it straightway goes to the artery. And this is, the nature has provided this phenomenon only in the upper third of the vagina. So from a vein, it goes to the artery, and artery, uterine artery, the supply is given to the uterine wall and the endometrium. So it has not to go to the general circulation, and the concentration is very high inside the uterus. So in spite of low serum level, the concentration in the vagina or concentration in the cervix, concentration in the uterus, it is always very high, and that is why the vaginal progesterone is always preferred. The uterine concentration is higher than circulating levels, and efficacy is same as an intramuscular progesterone. And that is why, because of the pain, now intramuscular progesterones have become almost outdated, and you can give the vaginal tablets can be given to the patient. These are some graphical presentations that you can see that how the vaginal progesterone from the vaginal wall, and that will cause the absorption. So that should be done particularly, that is always to be applied in the morning. No, slides cancel.
So you're
Just a minute, please. I think I'll take only 5 minutes more.
Slides are on now. Slides are on now, sir. We can see the slides.
Oral progesterone, micronized form, is metabolized in the liver after absorption or fostering receptive endometrium, ineffective in inducing an in-phase endometrium. Now, you should remember that any oral progesterone, if it is given, then the in-phase endometrium is not found, which is found with the vaginal progesterone. Now the SR tablets are available. I think more than 25 companies in India have come out with an SR tablet, but still the international trials on these tablets are not available, and unfortunately it is not available in the other countries. So we are still waiting for the results. But for the convenience, I think lots of people are giving the SR tablet, but they are not giving the SR tablet single as a progesterone support. They are adding vaginal tablet, they are adding injections also, they are adding some other drugs also. So that is why still it is very much doubtful how much efficacy is there of an SR tablet, and we are waiting for the results. Now about a dihydrogesterone. Two things I would like to mention about this drug. That this drug is not effective when endogenous progesterone is absent, and that is why dihydrogesterone is not useful as well as all the freezing transfers are concerned. When you are giving estrogen progesterone from the preparations of the endometrium, dihydrogesterone does not work at all because the endogenous progesterone is absent. So whenever you use dihydrogesterone, you don't know whether the endogenous progesterone is working or whether the dihydrogesterone is working. And the trials which are done, I think unfortunately since the drug is available since more than 60 years, and there is only one trial, that is the Lotus trial, that is available to us now. And in that Lotus trial, they have compared the vaginal progesterone with 600 units only, 600 milligram only. Now, if you see the papers, that cyclogest Spessary, which is available in Western countries, that all IVF centers are using 400 milligram BD. So that is minimum 800. And if you compare it with 1200 milligram, I think the results with vaginal tablets are much better than the dihydrogesterone. And second thing, it is not effective in the freezing cycles where the endogenous progesterone is absent. So oral dihydrogesterone is not effective in priming a pre-decidual endometrium in mock ART cycles. So it does not work when the endogenous progesterone is absent. Vaginal progesterone administration and not in the dihydrogesterone results in decrease in the spiral artery pulsatility, RI and SD ratio. So that is why for a good vascularity, you require a vaginal progesterone. Now, the last few words regarding the progesterone resistance, that there are two conditions. One is an endometriosis and second one is the PCOS. These are the two conditions in which the progesterone resistance is there. So in a PCO, either you can use it, OC pills for 3 months. And in an endometriosis, you may give GnRH agonist for 3 months. And then if you give a progesterone, the implantation rate will be very high. Otherwise, the implantation will not be good. This is because of the progesterone resistance. Now, HCG as a luteal support can be given. I have already discussed the 1500 units by Humedian. But in future, 100 to 150 units of HCG can be given daily in a luteal phase. And perhaps that may be the single drug that will be utilized in future for a luteal support. But we don't have the HCG available in a pen preparations. And that is why we cannot deliver 100 to 150 international units of HCG. And that is why that is not possible in India at present. GnRH agonist, there are only 2 papers available, but it may be a toxic for the pregnancy or the implanting embryo, and that is why it is not used nowadays. Role of E2 supplementation, E2 is always to be given to 2 groups of patients. One, whenever you have used GnRH agonist as a trigger, the luteal support, along with the progesterone, you should give estradiol to all these patients. And second is when you are using a long protocol, at that time also you should give an estrogen support to these patients in the luteal phase. Now, onset of luteal support, it should be started any day starting from the day of pickup, but it should not be later than 3 days of ovum retrieval. So any day, whether from the day of pickup, next day of pickup, or previous day of pickup also, or the day of HCG, the pregnancy rates are the same. The only thing that it should not be later than 3 days of an ovum retrieval. And when you can stop luteal support, when the beta HCG is positive, you can definitely stop it, but nobody does in this India. It can be stopped at 5 to 7 weeks by majority of the centers, but majority of Indian centers, they continue up to 9 to 10 weeks of pregnancy. In FET cycle, continue at least up to 10 weeks as there is no corpus luteum. Otherwise, if the corpus luteum is present, if you have done it in a fresh cycle, then you can stop any time, either from beta HCG positive to 10 weeks of pregnancy. The results are the same. So my carry-on message, luteal phase support is must in superovulation with gonadotropin. HCG trigger is avoided in the patient with the high risk of OHSS. GnRH agonist and antagonist use demands luteal phase support. GnRH agonist trigger, luteal phase support is always required. GnRH agonist trigger is a choice in a patient of high risk of OHSS, donor cycle, PGS, PGD, and freeze-all cases. Dual trigger or HCG at the time of pickup is the usual remedy for the fresh transfer. Luteal phase support is not required for natural cycle or modified natural cycle. Results of artificial cycle are also the same. Vaginal progesterones are always preferred in the present scenario. Subcutaneous progesterone has replaced the intramuscular route. Dihydrogesterone and the oral tablets are under the trial. Low dose HCG may be an option in the future for the luteal phase support, and start luteal phase support from the day of an IUI or ovum retrieval, and can be stopped after the beta HCG is positive, except in FET cycle when it is continued for 10 weeks. Thank you very much.
Thank you, sir. Thank you for a beautiful talk. As always, it's really, really, really lovely to hear you. and such clear carry home messages. So I think in the beginning only I said that we should use only one progesterone. Sir has also made very clear that you are using vaginal and subcutaneous injection or intramuscular injection on every alternate day. No need to use dydrogesterone or any other oral progesterone and injection SCG unless it is required in some patients where you cannot use other preparations. So thank you, sir. Thank you for a very good talk. As always, it's really nice to hear you. I'm a big fan of yours and it's really good. Thank you, sir.
very
Thank
much.
you so much. Thank you.
Thank you. That was a nice session. Thank you, Nagori sir. Thank you, Chandra madam. Very enlightening talk indeed on progesterone. Many queries answered. Whether one thing about dydrogesterone, that we all are using it so commonly. With this, we move on to another role of progesterone, that is during pregnancy and labor. I take the privilege of calling upon Dr. Aparna Sharma as the speaker for this session and Professor Anuradha Khanna to kindly chair this session, ma'am.
Thank you.
I take the privilege of introducing Professor Anuradha Khanna, madam. She is the ex-head of the Department of Obstetrics and Gynecology, Banaras Hindu University, Varanasi, ex-president of Varanasi Obs Gynae Society. Currently, she is the president of UP chapter of Obstetric Gynae Society, has many credits for organizing many conferences to her credit, and has been awarded with many publications and many awards to her credit. I welcome you, madam, for chairing this session and to kindly introduce the speaker for this session.
Sure. Kindly show me the slide.
Mr. Ramesh, please share the slides of Dr. Aparna Sharma ma'am, CV slide.
So I will speak even before. It's my profound privilege to introduce Dr. Aparna Sharma, who is brilliant list and all through topper of the batch from the Institute of Medical Sciences. This is our privilege. I was her teacher and she is such a student of our institute. And I'm so happy that today she is additional professor at All India Institute, Division of Fetal Medicine. And she is working a lot on it. And we used to refer the cases from Varanasi to her and take her opinions also. She is Dr. Kamini Rao Oration, 2017, Fox's Junior Korean Award, 2018, Fox's Son, IACC International Traveling Fellowship, 2019. She is a Legend of Tomorrow Award by NZY Foxy 2019. That is your Foxy. Foxy Imaging Science Committee Award 2019. North Zone Coordinator, Safe Motherhood Committee, Foxy 2020 to 23. She is co-chairperson of AOGT Quality Committee 2019 to 21, co-convener of Early Pregnancy SIG Indian Fertility Society. She is joint secretary of AOGD 2019 to 2020, North Zone Coordinator, Practitioner Obstetrics Committee, Foxy, member of Fetal Medicine Subcommittee, AOGD 2015-17, member Executive Committee, Society of Fetal Medicine of India, 2018 to 20, and several publications in international peer-reviewed journals. And we will love to listen you, Dr. Aparna, about preterm labor, all the prophylactic and actually preterm labor, where to diagnose and how to manage it. So go ahead with that. Thank you.
So very good evening to all of you, and thank you, ma'am. And it's actually has been my proud privilege to be your student and a part of IMS BHU. And I think IMS BHU has given me such a a solid base to be where I am today, and I've always been a proud student of that place. So today I'll be talking about, after two illustrious speakers, I'll be talking about the role of progesterone in preterm birth. So I think this is one of the most contentious topic today, and how it goes about progesterone. So I think this is something called the magic of validation. So we will give progesterone. Whatever we do, we will give progesterone. And somewhere we are looking for validation for what we are doing. So the talks that we've had before us, the talks we are going to have just now and in the future also, we are looking for a validation for our practice. So I'll be talking about progesterone under various headings in pregnancy. So let me be very clear. Let us not confuse about what I'm talking. I'll be talking about the role of progesterone in preterm labor in pregnancy. I am not talking about the role of progesterone in abortion, in threatened miscarriage, in rectal pregnancy loss. All of this I'm not talking about. What I am talking about right now is only the role of progesterone in preterm labor. And there is so much material on it that, there is, if you actually go into the depths of the evidence, we can just not get, we can just keep getting confused about it. But there is still a lot of synthesis of evidence which is possible. We can get actually some direction after we actually synthesize the evidence, right? So how does actually progesterone act in preventing preterm birth? We all know that progesterone works on the from the corpus luteum, helps in maintenance of pregnancy till 7 to 9 weeks till placenta takes over, and it maintains the uterine quiescence in the later half of the pregnancy. It prevents apoptosis in the fetal membranes and thus protects from the preterm premature rupture of membranes, and also it inhibits the inflammatory cells and inhibits the MCP1, a pro-inflammatory substance. So these are the various mechanisms of actions by which the progesterone is functioning and based on which we are expecting it to function. Now, which are the exact pregnancies which are likely to benefit from progesterone? And this is the first thing that we are going to discuss. So the first one is that those are the pregnancies which had a previous singleton preterm birth. Now, we know that one single preterm birth is one of the highest risk factors for the next preterm birth. And I think this is one thing that we've been taught by our teachers. We teach our students that one single factor, which is the highest risk factor for preterm birth, is a previous history of preterm birth. Now, how does progesterone work and what are the trials which have shown benefit? Now, this is a Cochrane review, which was done in 2013, and it showed that out of the 11 trials in 1,899 women, progesterone supplementation resulted in lower risk of preterm birth and neonatal morbidities in terms of birth at less than 34 and 37 weeks and neonatal death. So in 2013, this Cochrane review talked about the benefit of progesterone. And this Cochrane review most definitively involved this particular trial, which was done by Meese in 2003. Now, this is the one which started everything. And in 2003, they talked about the Proluton, as we most commonly know, the intramuscular progesterone, 17-alpha hydroxyprogesterone caproate, which for the first time documented very effectively that if we start giving weekly intramuscular progesterone in women who have a previous history of preterm labor, then we will reduce the risk of preterm delivery. So this was a landmark trial which was published in NEJM in 2003. And coming very closely with this was the another trial by Fonseca et al. In 2003 at the same time. This was done in 142 women, and they supplemented vaginal suppositories. And they also said that in those women who are at high risk for preterm delivery, even vaginal progesterone works well. So by 2003, we were quite happy to believe that vaginal progesterone and intramuscular progesterone work well to prevent preterm labor, and we were happily practicing giving progesterone. However, because we are not happy with one evidence and newer evidence keep on coming, so then there were newer trials which showed something else, of which this optimum trial, which came in 2016, was the one of the biggest culprit. Now, what did it show? This was the largest trial on effect of progesterone administration on obstetric, neonatal, and childhood outcome. Now, this was one of the largest trial involving 1,000 and 1,228 women, which gave vaginal capsule progesterone in the form of vaginal capsule, 618 almost in both arms, in women who were at high risk of preterm delivery. And what did they find? That if you talk about whether it is a obstetric and neonatal outcome or a childhood outcome in terms of long-term neurodevelopmental outcome at 2 years, there was not much of a difference. So this optimum study rather shook our belief in progesterone. So this study came in 2016. This study actually was a very well conducted study, well designed, well executed, and 2/3 of the women in the progesterone group were actually compliant to progesterone. They took progesterone. But they also said that while vaginal progesterone supplementation did not significantly reduce the preterm birth, it did reduce the frequency of neonatal death and sonographic evidence of brain injury, which, however, did not result in an improvement of neurodevelopmental outcome at 2 years of age. So this optimum study actually created a lot of ripples, lot of waves on the effect of progesterone on preterm birth. Close on heels of this optimum study came the progress study. Now, this progress study talked about vaginal progesterone pessary. And this pessary also was given in 787 women, again with a history of preterm labor, previous preterm birth. And they also said that if you looked at the adverse infant outcome, perinatal mortality, IVH, NICU admission, again, there was no difference. So whether you gave vaginal capsule, whether you gave vaginal suppository, both these studies did not show any difference. So this was 2016, 2017. And then finally, so again, maternal outcome, fetal outcome, there was no difference. So this study also did not support the use of vaginal progesterone in women with a history of spontaneous preterm birth to reduce the risk of respiratory distress or neonatal morbidity or mortality. So now if there was no improvement in respiratory distress, then what are we actually doing? Now, with all of these things happening, then came the prolonged study, which actually, I would say, proverbially hit the last nail in the coffin for progesterone for some time. And this study actually came in 2020 January. Now, when this came in 2020 January, so this is just 1 year back. And this prolonged study came in 2020 January. This was again in previous history of spontaneous preterm birth, but this time it used IM progesterone. And they said that there was no difference in neonatal outcomes, and they actually recruited a large number of women, again 1,000 women, and they said that there was no improvement in neonatal outcome even if you give IM progesterone. So vaginal progesterone, no improvement; IM progesterone, no improvement. But again, no improvement in miscarriage and stillbirth. So these people again concluded that in women with a prior history of spontaneous preterm birth, weekly IM progesterone did not reduce recurrent preterm birth or decrease neonatal morbidity. So after the prolonged trial, what did US FDA advisory committee said is that maybe the approval for Mecana should be withdrawn. So Mecana is IM progesterone, and it is one of the revolutionary drugs which was actually given a recommendation for prevention of preterm labor after the MEAS trial in 2003. So this was withdrawn in 2020. Now this is something which was very, very landmark. So currently, with all of these controversies, where are we with progesterone? And at the same time, are we actually comparing apples with oranges? Did MEAS in 2003 the trial that MEES did in 2003 compared the similar population in PROLONG in 2020. So this is what SMFM said. So from controversies to consensus, did MEES in 2003 compare a similar population in PROLONG in 2019? So this is what was the whole controversy about. While MEES in 2003 dealt with a more higher risk population, PROLONG in 2019 represented a population which was more similar to a normal risk population. So after re-looking into the both trial population, SMFM, Society for Maternal Fetal Medicine, came out with a statement in 2020. So all of this has happened just last year. They said that the difference in the results from the MEES trial may be partially explained by the differences in the study population. So it's recommended to continue the use of 17-OHP in women with a profile representative of a very high risk population reported in the MEES trial. And hence, a shared decision making is recommended, and risk benefit discussion with high risk women taking into account the short term safety concern but uncertainty regarding benefit. So they said that do not write off progesterone as of now, because even though the prolonged trial did not show benefit, the patients who were recruited maybe were not as high as risk as the MEES trial. So there is a difference between the people who were recruited. So the evidence has to be interpreted with care. So this is the first group of population that we discussed, was those who have a previous history of preterm labor. Now we know the other group is the patients who have a short cervical length. Now, the story we remember started in 2003 with the population of a previous preterm labor. Now, the short cervix history, so there is a systematic review in 2018. Now, interestingly, this systematic review in AJOG, and this says a report of major impact, because, after the optimum trial, which says vaginal progesterone has no role, so that was the optimum trial. So this meta-analysis, they actually included the people of the optimum trial, and they took the population of short cervix, and they came out that of the people with the short cervix, with a cervical length of less than 25 mm, vaginal progesterone is associated with significant reduction in the risk of preterm birth. So if the cervix is short, then vaginal progesterone does have a role in prevention of preterm birth. So current evidence says, vaginal progesterone has a role in reduction of preterm birth if the cervix is short. But then again, we should know which are the pregnancies where there does not seem to be any role of progesterone. If there is a singleton pregnancy now with a previous pregnancy which had a preterm delivery because of a twin pregnancy. Now we know that twin pregnancy itself is a risk factor for preterm delivery. So no study has really specifically evaluated the issue. A benefit might be possible, but we don't know whether the previous preterm birth was because of a twin pregnancy. So even if we do not supplement progesterone in this setting, it is a reasonable understanding because there is not enough evidence. That is number one. Number two, now we are so tempted to give progesterone that even after cerclage, we are tempted to give progesterone. With a prior spontaneous preterm birth, short cervix, we have placed a cerclage. Now, continuing IM progesterone has not been proven to reduce preterm birth, but the available data is limited and underpowered. And there are certain institutes and certain people who do practice continue giving hydroxyprogesterone IM. So there is not even enough evidence. The evidence which is there are underpowered and they have not shown any benefit. So it is not really recommended that you continue giving progesterone after cerclage. Now, if the membranes have ruptured, then do you give progesterone? Now, in the current pregnancy, after rupture of membranes, giving progesterone does not prolong the latent period, increase gestational age at delivery in a singleton pregnancy. However, in this pregnancy, if a patient has ruptured in the next pregnancy, then definitely there is a role in prevention. So if a woman has a history of PPROM, then giving progesterone in this pregnancy makes sense. There is some evidence to it. Is the role of progesterone in the treatment of threatened or established preterm labor? Meta-analysis from 4 RCTs has shown that progesterone therapy did not reduce the preterm birth at less than 34 weeks or delivery of infants of less than 2,500 grams. So even if we are using the progesterone, it has been seen that it is dihydrogesterone rather than the vaginal progesterone or IM progesterone, which has a role in threatened preterm labor. So as of now, if there is preterm labor, we need to give tocolytics and steroids rather than progesterone. Now, maintenance therapy after threatened preterm labor. Patient had threatened preterm labor at 28 to 30 weeks. Do you continue progesterone? The use is investigational. Mostly it is not recommended to continue progesterone. And most of the studies, they have been found to say that progesterone is not more effective than placebo. What is the role of progesterone in twin pregnancies? In multiple gestation, progesterone is not effective in unselected multiple gestation. Now, if just for the sake of multiple pregnancy, giving progesterone is not justified, because we know that the pathogenesis of preterm labor in multiple pregnancy is different from that in singletons, and it is not impacted by giving progesterone. So in unselected twin pregnancies, in a meta-analysis, it was found that giving progesterone, whether it is hydroxycaproate or vaginal progesterone, did not reduce the risk of preterm birth or improve the neonatal outcomes. Now, if there is twins in the current pregnancy and prior singleton birth, preterm birth, so the patient had a previous singleton preterm birth, so she is at a risk of preterm birth in the present pregnancy, and on top of that, there is twins. So now there is a double hit kind of a thing. So she had a history of preterm birth, plus she is twins. Now, optimum management is clear. Logic says that it is logical to give progesterone. Treatment can be offered, but controversial. So we don't know whether the progesterone is working. Not providing progesterone supplementation is reasonable because we don't know how much it is effective. So there is not enough evidence to say either way. Now, twin pregnancy with short cervix, 6 RCTs have shown that with a cervical length of 25 mm, vaginal progesterone reduced the preterm birth. So giving progesterone is a possibility, but needs to be confirmed on larger trials. Is there a role of intramuscular hydroxyprogesterone in twins with short cervix? There is generally no role of intramuscular hydroxyprogesterone in short cervix in general. No twins. There is a role of vaginal progesterone in short cervix. So in twins also does not appear to be beneficial. Uterine anomaly and progesterone assisted reproductive technology and unselected progesterone, although they do appear to be at increased risk of preterm birth, giving progesterone does not definitively seem to reduce the risk. The evidence does not support a use of progesterone to reduce the risk of preterm birth. Now the question comes, which progesterone? Vaginal progesterone, IM progesterone, oral progesterone. So there was this recently published July 2020 Victoria study which compared vaginal progesterone with intramuscular progesterone for preventing preterm birth in high-risk pregnant women. So this compared the efficacy of 2 different regimens of progesterone therapy, daily versus intramuscular, and compared vaginal and intramuscular for the prevention of preterm birth. So vaginal group took 200 milligram of micronized natural progesterone daily, while the intramuscular took 250 milligram of 17 OHP weekly from 16 to 22 weeks to 36 weeks. And compliance was also seen. And they found that the difference in the risk between the 2 groups there was actually not much of a difference between these 2 groups. And other outcomes were also comparable in terms of the amount of preterm delivery. However, the compliance was better in the vaginal group as compared to IM group. So according to Victoria study, vaginal progesterone is comparable in efficacy with intramuscular progesterone in reducing the recurrent preterm birth in high-risk pregnant women. So actually, what is the difference between IM and vaginal progesterone? So when you look at the vaginal progesterone, it decreases the myometrial contractility and prevents cervical ripening. IM progesterone does not possibly affect the cervical ripening. It has a differential effect on prevention of membrane weakening, and hence it prevents the PPROM. Natural progesterone has a greater binding affinity for the nuclear progesterone receptors than hydroxyprogesterone acetate. Now, is there a role of oral progesterone? Now, we know that there are trials for oral progesterone. So there is possibly a role for oral progesterone in preterm labor. Needs to be seen more. More trials are required. But there are trials which show, even trials from India have shown for a role of oral progesterone in prevention of preterm labor. So let us just see what our guidelines and clinical recommendations, just to summarize what all I have said. So I think there is a lot of evidence, there is a lot of confusion, but there are just two plain and simple points for us to take home. Clinical recommendations say that if there is a history-based indication for progesterone, history of spontaneous preterm singleton or history of spontaneous preterm twin birth, then history-based, we need to give 17 OHP weekly. Now with the Victoria study, they say that even vaginal is good. But traditionally, we have believed that history of spontaneous preterm birth, we can give intramuscular injection for prevention of preterm birth and monitor cervical length. If the cervical length is less than 25 mm, then prophylactic vaginal progesterone or cerclage can be given. If there is a short cervical length, then in that case, vaginal progesterone is recommended as a suppository, tablet, or a gel. If there is a PPROM, then is the progesterone recommended? No. If there is a threatened preterm labor, no progesterone recommended. Positive fetal fibronectin, no progesterone is recommended. If in the current pregnancy, if there is a twin pregnancy with a history of spontaneous preterm birth, previous history of spontaneous birth, there is a possible role of progesterone. And because it's a history-based recommendation, we would prefer to take IM progesterone. Again, with twins with short cervix, we would take vaginal progesterone. So only two themes emerge: history-based recommendation, IM progesterone; short cervix, vaginal progesterone. SMFM statement 2020 states that assess the risk of recurrent preterm birth, do a risk-benefit discussion with the parents. If it is at very high risk of preterm birth, start them on IM progesterone. Not a very high risk, go for a shared decision making. Look for serial cervical length. Cervical length is less than 25 mm, go for a cervical cerclage. If it is more than 25 mm, then you can continue as before. If there is no history of prior preterm birth, again, you look for a single cervical length as a part of the level 2 scan that we normally do. If cervical length is very short, then we need to consider vaginal progesterone because there is no history of preterm vaginal birth. And if the cervical length is more than 20 mm, then we go for routine care. So this is a practice-based recommendation which has been given, approved repeatedly. So the practice points would be that a previous preterm birth is the strongest clinical risk factor for preterm birth in the current pregnancy. Recurrent preterm birth, 1.5 to 2-fold increased risk. Detailed history to look for risk factors in the previous pregnancy. Differentiate spontaneous preterm birth from iatrogenic preterm birth. Reasonable to use 17 OHP in women representative of high-risk population. Cervical length measurement should be done in all pregnancies at risk. In all pregnancies at 19 to 23 weeks. Thank you.
Thank you very much, Dr. Panna, for a very nice deliberation. And your talk was very, very informative. One thing I will like to comment on this, that while we are seeing the cases, we have to also think of infections. That preterm labor, why she is having preterm labor, there are different etiopathogenesis, but especially I found that infection should be taken care. And as you mentioned in TIFA, you see the cervical length. Nearly, say, I will say around 24, 26 weeks. We should also have an ultrasound, not to see only fetus, but to see fetal adrenal cortex. Because any stress in pregnancy is going to affect fetal adrenal, one of the thesis has been done under me, and we found when this fetal cortex was high, that means more fetus is secreting more adrenaline, and she's likely to go in preterm labor. That can also be included while we are doing ultrasound, say after TIFA onward. And also, we should investigate not only just by we are putting the transducer to see the cervical length, whether abdominally or anything. There should be also investigation for vaginosis. A very simple test is MCEL criteria and Nugent scoring. That should also be done, and we should find it out whether she needs any treatment for infection or not, because PPROM is a late pathology. First, we will have this uterine contraction, not necessarily in infection. Always PPROM will be there. That may be a cause of preterm labor. So that's what I do in my practice, that while taking the history, as you very rightly mentioned, about the previous singleton preterm birth, the twin pregnancy, the short cervix, and we should find out why she is having it. Because not only this, these infections are likely to have effect on the cerebral palsy, that is brain also affected, and we must treat them accordingly as we find it out. Thank you, the Sun Pharma and the IFS for making me the chairperson here. And thanks a lot, Dr. Archana. Dr. Aparna, I would like to listen more from you if you want to say.
Thank you, ma'am, for your comments. And as usual, they're very, very practical and patient oriented. Always nice to learn from you more and listen to you always. Thank you, ma'am.
Thank you.
Thank you. With this, we come to the end of our CME today. Is Dr. Nina there? Okay, with this, I take the privilege of thanking all of you, especially the IFS, Dr. Sudha Prasad ma'am as the president and Dr. Nina Malhotra ma'am as the general secretary, for giving us this wonderful opportunity to go through this journey of progesterone, how it is important right from the initiation of conception right up to delivery. I'm thankful to all the faculties who made tremendous effort in making this CME successful. The chairpersons, Dr. Manoj Chelani, Dr. Sunita Chandra, Dr. Anuradha, and the eminent speakers, Dr. Neela Malhotra ma'am, Dr. C.B. Nagori sir, and Dr. Aparna Sharma ma'am. With this, also, I would be at a loss of words if I don't make a special mention for Sun Pharma, who has actually made it possible for this CME to happen. With this, I take the privilege of ending you all. Especially, there are two Manojas. There are three Manojas involved in this CME. One is Dr. Manoj Chelani, and the other is two Manojas from Sun Pharma. I would like to acknowledge both of you. Shani from Sun Pharma, thank you so much for all the efforts. Thank you. I hand over to Sun Pharma.
Thank you.
Thank you. Thank you so much.